All right, future nurses, welcome. Today, we are diving deep into one of the most intense situations you'll ever face, the initial management of a burn patient. What you do in those first few minutes, those first few seconds, it can literally mean the difference between life and death. So let's get right into it.
So, picture this. The ambulance doors fly open, the scene is chaotic, and you see a patient with severe burns. Your mind is racing with a million things you could do. But what is the one thing, the absolute first thing you must do? That's what we're here to figure out. So here's our game plan. We're going to start with that big question. What is the first priority? Then we'll get into how the source of the burn, what actually caused it, changes your immediate actions. After that, we'll uncover the deadliest and often invisible threat in burn injuries, the airway. Then we'll dig into the science of burn shock, why all that fluid is shifting around. And finally, we'll put you to the test to see what you've learned. Okay, Section 1, the first priority. Let's not waste any time. These first few steps aren't just important, they are the entire foundation for your patient's survival. It really boils down to these three things in this order. Number 1, stop the burning process. I know it sounds obvious, but if the patient is still on fire or in contact with a chemical, nothing else you do matters. Second, secure that airway. We're going to talk a lot more about this, but it is so often the most immediate life threat. And third, and this is a huge takeaway, you have to treat this person as a trauma patient first and a burn patient second. It's a total mindset shift. A major burn affects every single body system and can easily hide other life-threatening injuries. And that brings us to this critical point. Burns, even really bad ones, don't typically knock someone out right away. So if your patient is unconscious, you have to become a detective. Why? Did they fall? Did they hit their head? You absolutely cannot get tunnel vision on the burn itself. You have to hunt for those other injuries. Okay, moving on to Section 2, identifying the burn source. Knowing exactly what caused the burn is key because it completely changes your immediate response. This is a great little cheat sheet. For flames, you smother and then use cool water. And I mean cool, never ice. Ice causes intense vasoconstriction and can make the tissue damage way worse. For chemicals, it's all about dilution. Get those clothes off and just flush with tons of water. Now, tar is a weird one. You cool it down to stop the heat, but you leave it in place. Don't try to peel it off, you'll just rip off the skin with it. And finally, electrical burns. Your number one priority is your own safety. Make sure that power source is off before you even think about touching the patient, and always assume they have a spinal injury. Electrical burns are the great pretenders. The little entry and exit wounds you see on the skin, that's just the tip of the iceberg. The real damage is the path of destruction that current burned right through the inside of the body. That's why you can't use the size of the skin burn to calculate fluids. Instead, your best window to the inside is their urine output. And if you see dark, foamy urine, that is a massive red flag. It means muscle tissue is breaking down, releasing a protein called myoglobin, which will clog up the kidneys and cause them to fail. So your priority is to crank up the fluids to flush those kidneys out. All right. Let's pivot to the thing that's often the biggest killer in a fire, and it's something you might not even see at first. Section 3, the unseen airway threat. Yeah, let that sink in for a second. It's not usually the flames on the outside that are the most deadly part. It's what the patient breathed in. The vast majority of deaths from fires are due to respiratory complications. That's why you have to have an incredibly high index of suspicion for this, especially if they were trapped in a closed space. So these are the clues you are hunting for. Get right up and look at their face. Do you see burns around the mouth or nose? See any singed nasal hairs? Is their voice hoarse? Are they coughing up black, sooty gunk? Any one of these is a giant, flashing red light that their airway has been cooked by superheated air and is about to swell shut. We're talking minutes here. You have to be ready to act fast. And inhalation injury isn't just one thing. It's actually 3 different problems. You've got carbon monoxide poisoning, which affects the whole body. You've got that upper airway thermal injury, which causes all that swelling we just talked about. And then you have the sneaky one, a chemical injury to the deep parts of the lung, which might not even show symptoms for a day or two. 200 times, that number is everything. This is why carbon monoxide is so deadly. Hemoglobin, the little molecule that carries oxygen in your blood, likes carbon monoxide 200 times more than it likes oxygen. So, if both are around, CO wins. It jumps into all the seats on the bus and kicks oxygen out, completely starving the body. So, what's the fix? It's pretty simple, actually. Blast them with 100% oxygen for at least 3 hours to try and force that CO off the hemoglobin. But here is the single most important thing to remember, and you will see this on exams. A standard pulse oximeter is completely useless. It's lying to you. It will read a beautiful 99% or 100% because it can't tell the difference between a hemoglobin carrying oxygen and one carrying carbon monoxide. It's a trap.
Okay, so we've dealt with the outside, we've dealt with the airway. Now we have to fight a massive crisis happening inside the body. Section 4, Understanding Burn Shock. This is the why behind your patient's blood pressure circling the drain.
At its core, burn shock happens because the body's plumbing starts to leak everywhere. The massive inflammatory response to the burn makes the tiny capillaries lose their integrity, so all the fluid that's supposed to stay inside the blood vessels starts pouring out into the surrounding tissues. We call this third spacing, and it's why the patient's blood pressure plummets. Let's walk through it step by step. First, the burn damages the capillaries, making them super leaky. This allows big protein molecules to escape into the tissue. Now, wherever protein goes, water follows. So massive amounts of fluid follow that protein right out of the bloodstream. And what's the result? The vascular space basically collapses, and the blood pressure just tanks. And that brings us to our number one job in this phase. If the patient's tank is leaking, our goal is to fill it up faster than it's leaking out. Aggressive fluid replacement, we're talking huge volumes of IV fluids, is the absolute cornerstone of managing burn shock. We have to stay ahead of that leak to keep their organs perfused.
All right, that was a lot of information, I know, but now it's time to see what's stuck. Let's run through a couple of quick scenarios and put your knowledge to the test. You ready?
First one, you've got an electrical burn patient and you notice their urine is dark and foamy. What's going on and what's your first move? You got it. That's myoglobinuria. It means there's massive muscle damage. Your priority is to immediately increase their IV fluids to get that urine output up to at least 75 milliliters per hour. You gotta save those kidneys. Okay, next up, you suspect carbon monoxide poisoning. What is the one thing that patient absolutely needs right now? The answer? 100% oxygen, high flow, for at least 3 hours. It is the only thing that works to kick that CO off the hemoglobin. Here's a big one. The monitor is showing a beautiful oxygen saturation of 99%, but your patient from a house fire is confused and barely awake. Why can't you trust that number? Right, because the pulse ox is being fooled. It can't tell the difference between oxygen and carbon monoxide, and it's giving you a deadly, false sense of security. Always, always trust your clinical assessment of the patient, not just the monitor.
And for our last question, let's think bigger picture. You've done it. You've stabilized them, you got them through that initial crisis. But their journey is just beginning. What comes next? Well, you'll be facing massive challenges with infection control, incredibly complex pain management, providing enough nutrition to heal, endless wound care, and of course, the immense psychological trauma. The initial management we cover today is the first vital step on a very, very long road. And your skill, your knowledge, and your compassion are what will get them through it. Thanks for joining me.